that really easy flow, and making sure your patient's not getting up and down, and then it's just more complicated than it has to be. One of the things that Ms. Marcus and I have found through the years is that if you go, so you do all head and neck, and then in the progression for what you learn in class, the next thing you do is cardiac. And you don't learn respiratory until later, but one of the things that we suggest you do, but you do not have to do it just does help with the flow of your head to toe exam, is once you do head and neck, if you'll do respiratory, that will help you go straight into cardiac, and I'm going to show you how that works, but just wanted to say it first. So let's just say that I've done my head and neck, okay, and rather than going into, I've done everything up here, I've palpated my lymph nodes, I've ended with, doing my supraclavicular, all of that, and rather than going right into my anterior cardiac, what works really well is if you'll go ahead and start with posterior respiratory. Because I'm going to do posterior respiratory, anterior respiratory, and then I'm right there ready to do cardiac with the patient sitting up. Then I can have them lie down, do cardiac, then proceed into abdomen. So does that make sense as far as flow? Again, you don't have to do that, but it just works really well. But so now let's just go straight into cardiac. So thinking about the first thing that you look at is skin, right? I'm going to have her whole back exposed, and I'm going to be looking at her work of breathing. Does she have any, using any accessory muscles? Do I see any retractions in the intercostal space, that sort of thing, looking at, and I would have her just sit for just a little bit. So I could see her whole back, and I would be looking, for intercostal retractions, that sort of thing. And then looking at the skin on her back. Okay, we're going to look at the skin overlying the respiratory system. So looking for any tattoos, any piercings, anything like that, and then looking at lesions, any moles. If I do see moles, do they fit within the ABCDE guidelines? Any birthmarks, discoloration, blemishes, anything like that, and I'm going to describe them and just say that they're there. If there's a big tattoo back here, I'm going to describe that there is a tattoo that describe how much of her back that it covers, and I'm going to assess is there any inflammation related to that, anything like that. So I've had students sometimes when they're in their head to toe assessment and there's this big tattoo covering the whole back, and they'll say, there's no discoloration, there's no anything like this. Make sure you're describing what you actually see. That's really important when you're doing an assessment on someone, is that you document what is there. So for her, I don't see any kind of increased work of breathing. I don't see any moles, any lesions, anything that would need to be commented on or measured or anything like that. So the next thing that I'm going to do, moving on, is I'm going to check for freminess, right? So when I touch you're going to feel me touching your back with both my hands. What I do, if you would just say 99 for me.
99, 99, 99.
Okay, so really it's like just 3 touches. Top, middle, bottom. If you've got tiny little hands, you might have to do one more, but we're just assessing and we're feeling for vibration. Okay, I'm going to go ahead because I'm here and I'm going to do CVA tenderness. So I'm going to come down right at the level of her kidney. I'm going to put my hand very firmly against her back. I'm going to bump against my hand. Just tell me if you feel any pain. Any pain associated with that?
No.
Any pain associated with that?
No.
No? Okay. And in general, do you feel any pain or tenderness when I'm touching on you? Okay, nothing. All right, so the next thing I'm going to do is I'm going to look for help me out with what it's called, chest expansion. Okay, so lean forward again. It would be better if I didn't have the back on this chair. So I'm going to come down just be right at the end of the bottom of the ribs. Okay, of the intercostal, the bottom of the ribs. I can't remember what it's called at this very moment. And so when you do this, you're going to go kind of to the outside of her ribs and pull in, okay? So it's a movement like this, to the side and then pulling in and up, okay? And what you're watching for when you ask her to take a deep breath is you want to see that your hands move symmetrically, okay? We want to see even movement of her chest expansion. So take a deep breath for me. And you guys are on the wrong side of me to see this, but I am seeing that my thumbs are equally moving out at the same time, in and out, okay? So her chest expansion is within normal limits. So I've inspected, I've palpated, I'm gonna move on now to, have I missed anything with that? Inspection and palpation, have I missed anything? This is not a test, I'm really asking. No, I think I've covered everything, okay? Now I'm gonna move on to auscultation. I'm gonna use the diaphragm side of my stethoscope. And you know, you wanna start up high because the top of, to catch the top of the lungs, you've gotta start way up here. So I'm not gonna put my stethoscope in so that I can actually talk to you. So I'm gonna start up here, and you're gonna do your ladder movement where you do 1, 1, go down 2, 2, right? All right, so every time that I touch your back, if you'll just take a deep breath through your mouth. And don't rush your patient too much because you don't want anybody hyperventilating. Deep breath. Again. Okay. And then I'm going to go over to the side, and then over to the other side. Deep breath and deep breath. Now, when you're going down and you're doing 1, 1, 2, 2, 3, 3, 4, 4, you can either do 5, 6, your sides all at one time, or you could do 5, 5, 6, 6. Either way is fine. I prefer comparing sides. I think Ms. Marcus teaches you guys to do one side and then the other side. Either way is fine. So just so you know that. So what I'm going to say after I have done my auscultation is that I don't hear any adventitious sounds. Her lungs are clear bilaterally. Any other descriptors that you guys can think of?
Rails, wheezing, and bronchi.
So no no rails, wheezing, or bronchi. Anything else? Other descriptors? No crackles? Okay, very good. So just, one of the things that you learn in this course is what is normal. Because if you don't know what normal is, you're not going to know what abnormal is, right? So that's great. All of those things that you can say you don't hear, that's really good. So that's it for the back side, I believe. Have I missed anything back here? Okay. It's pretty fast, really. I mean, if you think about it, that should take you, as long as everything is within normal limits, that should take you no more than 5 minutes, at the most. It's not, you've got to leave time, and you've got to give your patient time to take that breath in and out. You want to hear full breath in and out. And again, you don't want to rush them because you don't want them hyperventilating. And at all times, you're asking the patient, are you doing okay? You're observing, you're making sure that there's not any kind of swaying, anything that would indicate that, your patient might be breathing a little bit too deeply, too fast. But it moves along pretty quickly. What are you going to ask?
Do we assess for, I think it's egophony, or when they say A and it sounds like E?
E, yeah.
You don't have to do that for your checkup. The only thing, no, you're not. I mean, you're going to do your fremitus, the palpation, but no, you do not have to check for that. All right, so back side of respiratory is done. Now I'm going to move around to the front side, and you can sit back against the chair. So I'm starting with the same thing, looking at just the skin in general. I'm looking for any increased work of breathing, any intercostal retractions. Is she having to lean forward? Positioning. Is she able to position herself in a way that will help with breathing? So I'm making those observations. Then I'm looking at skin. Again, I'm seeing tattoos, piercings, any kind of inflammation, any sort of moles that do not fit within the ABCD guidelines, and everything associated with skin I would have described and everything is within normal limits. So I'm going to, now we're not going to do any kind of chest expansion, anything like that on the anterior side. But I am going to begin just with palpating and asking, is there any pain associated with my touch, okay, of the respiratory system? Okay. So then I'm going to start with auscultation, and again, you're going to start up here above the clavicle, right? So you can catch the top of the sounds. So again, when I touch your skin with my stethoscope, if you'll just take a deep breath through your mouth. Now you guys, when you are doing your checkoffs, remember, guys will have probably no shirt on. Ladies, you need to have like a sports bra or something like that, because I've got to be able to see skin. I've got to be able to actually get, you know, my stethoscope next to skin. But okay, so 1, 1, 2, 2, 3, 3, 4, 4. Okay, and make sure you get laterally. Make sure you get way over here. This is not a, you know, right at the side. This is pretty much up under the arm, down, you know, down from the axilla. And again, you can go side to side, or you can do both of the sides at one time. Okay, so I would again describe all those things that I did not hear any rails, bronchi, wheezing, no adventitious sounds, no increased work of breathing. And I think that is it for the anterior respiratory. Anything that I'm missing there? Okay, so that's really fast. And now you can see I'm going to go straight into cardiac. I've already done the skin assessment. Now don't forget that when you move, even though I've done the skin assessment, I've still got to do my inspection of the precordium, where I'm looking for any kind of thrills or heaves, that kind of thing, any movement of the chest wall from the, you know, underlying, from the heart. So you don't have to describe the moles, the tattoos, birthmarks, or anything like that again. But don't forget that you got to do the inspection of the heart. Okay? Any questions about that? It's pretty simple and fast as long as everything is normal. No questions? All right, then why don't you guys, let's spend probably about the next, I don't know, less than an hour, close to an hour doing your health assessment. I know that this week you added abdomen, so go ahead and you can either practice just abdomen, or if you want to go ahead and begin, you know, working with your whole incorporation